Fetal hydronephrosis. Okay, great. I think first it's helpful to go over what constitutes a normal-looking fetal kidney, at least on ultrasound, since that's our primary imaging modality. And one of the major differences between the fetal kidney versus the postnatal kidney, especially in older children, are the sonolucency of the pyramids. They can be really quite prominent, and sometimes people are fooled into thinking it's hydronephrosis, for example, depending on exactly how sonolucent it is. How do I advance? There we go. Okay, great. This will be a little interactive. So true or false, polyhydramnios can result from obstruction of the urinary tract. Okay, I'm not going to put anyone on the spot. So just think to yourself. That's a leading question. Hopefully you said true. And so we certainly, as urologists, are interested in AFIs. If they're low, obviously, we think urinary tract issues. But even if it's high, there's potentially obstruction going on. And one of the key signs of obstruction is hydronephrosis. And hydronephrosis is an umbrella term. It encompasses both chaliectasis, dilatation of the renal calyces, as well as pelviectasis, dilation of the renal pelvis proper. Okay. Now that being said, we'll go over in a little bit what constitutes some of the grading scales for hydronephrosis and how it relates to dilatation or lack thereof for the pelvis and the calyces. So one grading system for degree of fetal hydronephrosis, ANH is antenatal hydronephrosis, is looking at the AP diameter, which I would argue is just one parameter. But regardless, by the second and third trimester, there's different upper limits for AP diameter for mild, moderate, and severe, as you can see here. And I think one of the easier mnemonics is 4, 7, 10, 15, and you just shift it one classification according to trimester. So later trimesters, you're permitted, so to speak, a higher AP diameter. So you see how it's 4, 7, 10. This isn't quite 10, but it's close. Okay, so 7, 10, 15. And the reason that's important is because we do know that there are some loose associations between AP diameter of the renal pelvis and the likelihood of pathology. So that's PPD is positive predictive value. And you can see that as soon as you're about 5 millimeters or higher, it's more likely that you have pathology, although there's quite a range. And part of the reason I think there's quite a range is because the studies vary in terms of their criteria to obtain avoiding cystourethrogram to look for vesicoureteral reflux. Right? So if you don't look for reflux, you're going to have a lower positive predictive value, so to speak, for increased AP diameter being correlated with so-called pathology. Okay, and the reason that that's important is because reflux in almost all cases only matters if a child is prone to getting urinary tract infections. And so how hard you look for reflux depends on other postnatal factors, I would argue.
Are you surprised at that 15? Is that really 11%?
Mm-hmm. Yeah. Yeah. I mean, I think it reflects that the majority of hydronephrosis resolves on its own, even if it's moderately severe, and some of the severe cases. Now, that's an amalgamation of multiple studies and put together those numbers. So in another study, this was by Richard Lee in pediatrics. Again, if you look at severity of antenatal hydronephrosis by mild, moderate versus severe, your likelihood of ureteral pelvic junction obstruction where the renal pelvis meets the proximal ureter increases. Vesicoureteral reflux is not as well correlated, and that's because sometimes reflux is not associated with hydronephrosis. Okay, PUV, posterior urethral valve, is certainly more associated with severe antenatal hydronephrosis, as is ureteral obstruction and other diagnoses. So this is an important slide because you can see that the most prominent etiology is what we call transient hydronephrosis. It's also known as physiologic hydronephrosis. I like to use the phrase of families variation of normal to emphasize to them that the hydronephrosis will resolve on its own, and even if it doesn't, most of the time, it doesn't reflect any underlying pathology. All right. And then you can see here UPJ obstruction, reflux. You can also have obstruction at the ureteral vesical junction where the ureters meet the bladder, and that's typically associated with dilation of the ureters, megaureters. Multicystic dysplastic kidney, although there should be other characteristic findings on imaging, posterior urethral valve, and then things like ureteroceles and ectopic ureters. So I think this is a useful set of stats. During the third trimester, about a third of hydronephrosis will resolve, all takers, of course, and then half after birth, depending on the study you look at. So if you do those numbers, about 5 out of 6 kids will have resolved their hydronephrosis sometime after birth. So it's a very high rate. So the Society of Fetal Urology came up with a grading system for hydronephrosis. It goes from 0 to 4. 4 is really no hydronephrosis. Grade 1 is where the renal pelvis starts to split a little bit with urine. Grade 2 is where you have some dilatation of the major calyces. Technically, if you have filling of the intrarenal pelvis more than just splitting, it's grade 2. Grade 3 is grade 2, but also dilatation of the minor calyces, right, where you start to see some blunting. And then grade 4 is easy to remember because you have parenchymal thinning on top of everything else I just mentioned. Now, this grading system is not universally loved, and so people have tried to propose alternatives that haven't really quite been taken up widely. So Onens is one of them. And as you can see here, it tries to lump together SFU grades 1 to 3 as its own grade 1, and then it breaks down SFU grade 4 into whether or not half or less the parenchyma has been lost, so to speak, from the dilatation. Right. And I think part of the idea here is that very few of SFU grade 1, 2, or 3s have any underlying pathology, so why are we, breaking it down so granularly? So moving on to posterior urethral valves, where you have obstruction of the lower urinary tract because of the valve in the posterior urethra. Sonographically, at least, the classic sign is what's called a keyhole. So this is the bladder, and this is the posterior urethra, which is dilated, and this should not be dilated. Okay, so we're always looking for this in a male fetus if there's hydronephrosis. So what is the most common cause of oligohydramnios? You are correct, posterior urethral valve. Actually, I didn't hear you, but
rupture of membrane.
Yeah. So technically speaking, fetal bladder electrolytes is one way to prognosticate how well a fetus with posterior urethral valve will do. And you're looking at sodium chloride, osmolarity, et cetera, as you can see listed here. The issue is that this takes a tap, and so there's a fair amount of risk involved, I would say, compared to an ultrasound at least.
These numbers are
abnormal. Yeah, because the fetal urine is just hypotonic. Yep. It's prenatal. That's some weird feedback. So in terms of fetal intervention, I think the vesicoamniotic shunt for posturethral valve has been the primary intervention that's been explored, although some people have tried to do cystoscopic ablation of valves in utero, which is really technically difficult. Part of the issue with vesicoamniotic shunts is, first of all, sometimes we don't really know if a patient with a dilated bladder has a posturethral valve, right? So, for example, prune belly syndrome can cause it, but that's not an obstructive phenomenon. So putting in shunts in those patients is for the wrong indication, frankly. But let's assume you make the diagnosis correctly. That other indications for shunts include oligohydramnios, a patient with no chromosomal anomalies, and favorable bladder electrolytes, as I showed in the past slide, as well as lung immaturity, small lungs with oligohydramnios. It seems like shunts might be most helpful in that sort of setting. Not so much necessarily for prevention of renal failure. So there's other diagnoses, as I mentioned, that can be associated with a dilated bladder, and that's what in part complicates placement of vesicoamniotic shunts and doing cystoscopic ablation. So besides prune belly that I mentioned, urethral atresia, and so often you'll have a patent urachus in this setting as a pop-off valve for the bladder. And then Megacystis microcolon, which is also non-obstructive reason to have a dilated bladder. I mentioned ureteroceles in passing earlier. So a ureterocele is a cystic dilatation of the terminal part of the ureter where it inserts into the bladder. And you'll often have, but not always, a thick wall that's intramural within the bladder, suggestive of a ureterocele, and you'll typically have hydroureter and hydronephrosis behind it, that ureterocele. So ureteroceles can be what are called single system, meaning that there's one urine collecting system for the kidney in question, or part of a duplex system, typically the upper pole, all right, where there's two ureters on that side. If you ever see significant dilatation of a hypoechoic structure behind the bladder and the genitalia are not very clear, you have to at least consider the possibility that you're looking at a cloacal anomaly, where everything fuses together, right? Cloaca means sewer in Latin. So urinary tract, the distal rectum, and vagina, assuming it's a girl. So basically a common urogenital sinus. Now, other things you can see prenatally include things like very echogenic kidneys, which is suggestive of so-called medical renal disease, nephroptosis, and a number of other important nephropathies that are congenital. You can also see cystic changes, and there's different types of cystic changes. So if you see multiple cysts throughout a kidney of differing sizes, and the kidney seems small, and there's poor corticomedullary differentiation, that's suggestive of a multicystic dysplastic kidney, all right, which typically involutes over time and is non-functional. You can also see a lot of echogenicity and loss of corticomedullary differentiation and not a very reniform looking kidney. So that's also suggestive of dysplasia. If you see enlarged kidneys that are highly echogenic, at least corrected for gestational age, that could be suggestive of autosomal dominant polycystic kidney disease. And on MRI, some of the common findings besides hydronephrosis, isolated hydronephrosis, you can pretty clearly see cysts especially in the cortex of the kidney, very well on MRI. So this is a multicystic dysplastic kidney. You see how these cysts are not only in the cortex, but they're variable in size. And then the contralateral kidney not only has hydroureter and hydronephrosis, if you look carefully, you see a cortical cyst here as well, so suggestive of dysplasia, at least in that region of the kidney. So in terms of key data we look for in our fetal patients, I mentioned AFI, but of course the gender of the patient, because that determines, for example, if it could be a posterior urethral valve or not. Gestational age, how the lungs look, family history of cystic disease, or what we call catgut, congenital anomalies of the kidney and urinary tract. How do the kidneys look in terms of any dilatation, echogenicity, their size for gestational age, location, right, so you can have pelvic kidneys, for instance, horseshoe kidneys. We're looking for duplications. The adrenals can be helpful for determining renal diagnoses. You know, if you have the lying down sign of the adrenal and you're having problems finding the kidney, that may be renal agenesis. Okay, hydroureter is another thing we look at. There's multiple parameters we look at in terms of the bladder, how thick it is for its given level of dilatation, if there's any ureteroceles. Calcifications in the bladder wall can indicate prior perforation. And then dilated posterior urethra can be suggestive of a posterior urethral valve. And then the genitals themselves, sometimes the radiologist can spot a severe hypospadias, which never fails to impress me. Looking for the testes, sometimes they'll also see cryptorchidism, and whether or not there's scrotum or labia. If they're not, and you have a low-lying bladder, and you don't see any urine in the bladder, it could be a cloacal exstrophy, for example. Okay, so I'll end with a case. I hope the video works. This is a girl with antenatally detected hydronephrosis, as you can see here. So I would call this a 3, SFU grade 3, because not only are the major calyces dilated, but I think there's some blunting of the minor calyces. And then postnatally, we sorted out she had lower pole hydronephrosis, and it was a duplicated kidney. And we did an MRI to better define the anatomy. And so this is nice. You see how there's upper pole dilation, but the lower pole really does not. And so what she had was a crossing vessel. So it's very common to have multiple renal vessels supplying a kidney, and you can have the ureter drape over the lower pole vessel, and that can result in a ureteropelvic junction obstruction. And so after discussion, the parents elected for the patient to undergo robotic lower pole pyeloplasty. Oh, this might work. Or not. Yep. So just imagine a very nice robotic pyeloplasty. But anyways, it's a good illustration of how sometimes
the vessel diagnosed by MRI or ultrasound, or just when you went in?
I think there was a hint of it by ultrasound, but the MRI was extremely helpful for it. Yeah. But you know, the real point of this case is that sometimes these prenatal diagnoses do represent real pathology, and the postnatal follow-up is important. So we very much appreciate your help with these patients. So she was discharged on post-op day 1 and did great, and you see her hydronephrosis is much improved. Okay, so despite that case I just showed you, only a fraction of children with hydronephrosis will need surgery, but one of the guiding principles, one of the few Oxford, level 1 evidence principles we have is that the worse the hydronephrosis, the more likely that there's underlying pathology. But call us anytime. We're here and happy to help as we can.